Cardiovascular disease isn't just about clogged arteries or high cholesterol. It's a cellular problem that goes much deeper than most people realize. Chronic inflammation, oxidative stress, and hormonal imbalances, and even mitochondrial dysfunction are often the root cause of heart disease. Yet they're rarely addressed in conventional medicine. If you think managing blood pressure is simple as taking a pill, it's time to rethink everything you know about heart health. So joining me today is Dr. Abid Husain, a triple board certified integrative cardiologist and functional medicine physician who is redefining how we approach heart health. Dr. Husain's approach isn't just about living longer, it's about living better. It's about living better with a heart that's strong and resilient, optimized for longevity. So whether you're a physician, a wellness enthusiast, or someone just looking to take control of your cardiovascular health, this episode is packed with practical, cutting-edge insights you don't want to miss. Let's get started. All right. So Dr. Husain, welcome to the show.
Thanks, Greg. Pleasure to be here.
I know. I feel like I just saw you because I did just see you. Last weekend, we were in Calm down
right.
at a really amazing conference down in Miami, Florida. Really good times. And I really enjoyed your talk there as well.
Thank you.
So I did your intro. And the first question I always think, because again, I can tell you, man, with naturopathic medicine, there's always this little underlying the cardiologist hates us, right?
Yeah.
It's like, I don't know why, it's like probably because we're always like, medications and all that. It's a thing,
Mhm.
right? But again, to me, I think medicine should be collaborative and all that. And I think that
Yeah.
there's benefits in all types of medicine and how we practice. But for you, coming from the world of conventional cardiology, like how did you get into this functional medicine and like cellular medicine space?
When I was practicing, and this is the case with most cardiologists, we see end of the spectrum care. So I'm doing, I was practicing doing inpatient, outpatient work, and we'd see people in the hospital coming after the heart attacks, after heart failure, things like that. And it's a revolving door of care sometimes. And I just was tired of dealing with that end of the spectrum care. And the best therapy is prevention. So that led me to think about what's going on the other end of the spectrum. So and that also plays into one of my lifetime interests of fitness and lifestyle changes. I've always been an athlete. I've always been interested in what diet and exercise can do. And so I've always been curious about what it is about those activities and those processes that can be maximized. And so, putting those two things together and then going through a little personal process of having severe burnout. I was working in a solo practice for about, I don't know, 8 years, doing 12 days on, 3 days off. It's not enough time to recuperate. And then I was on call as well. And that also end of line care it's intense and it's not sustainable as a solo practitioner too. So all of that made me rethink where I was in cardiology and what my interests really were. And that led me to start investigating functional medicine, because some of the basis of functional medicine is diet and exercise. What is it that a good diet's going to do? And what other diets have their advantages and disadvantages? Because the more I learned, the more I wanted to be able to offer to patients. More patients were asking me, okay, well, I'm doing this. How's that going to help me? Or what can I do to modify my diet and optimize what I'm doing? So that's how I got into functional medicine. And then hand in hand with functional medicine goes hormone management. And that led me down a whole path of what it is that hormones can do for cardiovascular health. And then when I finished that, back to my interest in fitness and exercise. I was curious about what performance enhancers are out there, because as I learned more about testosterone, I'd always been fascinated about it. Of course, that's considered one of the original performance enhancing medications. What else can be used in addition to that? Well, that led me to peptides. And the first peptide I was considering using were CJC and ipamorelin, the secretagogues. But then after learning about that and learning about the power of growth hormone, endogenous growth hormone, it just exploded into all of the other peptides that we have available. So it was this progression of going through, I guess call it going through what it is that our body can do on its own, given the right circumstances.
Right. And that's awesome. Now, when I think cardiology, just when we learn in school, even naturopathic medical school, it's very algorithm driven.
Yeah.
It's like blood pressure's here, give this. If they're African American, don't give them this, but give them that. Or if
Yeah.
it's like, LDL's here, give them this. So knowing that you came from that and you learned, been diving pretty deep and seeing the success with the kind of the functional and cellular medicine,
Hmm.
does that change your approach? Where it comes like,
Hmm.
hey, your LDL's here, your cholesterol's here. This is how we're trained to do it. Do you
Yeah.
still go there first, or is it more? Does it give you more leeway per se when you're able to see it from that perspective?
Yeah. Uh, well, the approach has changed because it's
Okay.
now a personalized medicine approach, and even more so, the more people I see, and with the more tools that we have available to test patients, the more I realize it has to be a personalized approach. The reason why it was so population driven and protocol driven is because we didn't have a lot of specific data, and it wasn't really being applied to patients. I think that the modern era of testing, biometrics, wearable monitors, and AI has given us the ability to really crunch large numbers of data and determine what's good for the individual. And we can actually do that now, and get follow up testing quickly, as opposed to when I came out of fellowship 20 years ago, where that wasn't really an option. It wasn't available to the masses, and we really didn't have a good grasp of that. A perfect example is when we look at atherosclerosis and clearly scans. The conventional thinking is if your LDL is elevated, let's say if it's at 120, okay, we need to start a statin, and we need to do it because the studies show that's going to prevent atherosclerosis. Well, that may be the case for the majority of people, but there are a lot of people that can live with a LDL that's elevated, and we know that because they'll get clearly scans, they'll get CT coronary angiograms, and we won't see any plaque. So,
Hmm.
or we'll see minimal amounts, and we can use other interventions. So that's where the personalized medicine comes in. And it's not a cheap test, but it's still a test that can be done by the masses, and I would argue that it's worth it because you don't have to do it all the time.
Exactly. Now, that's a great segue because when people think about heart disease,
Hmm.
and again, we're going to talk about hypertension, high blood pressure, but just kind of staying in that lane of heart disease. When we think about it and we're trained on it, it's this whole thought process of cholesterol.
Yeah.
Whole thought process of cholesterol being too high and arteries. There's stenosis. There's plaque. There's this clogged artery concept. Why is that an oversimplification?
Yeah.
Is
Mhm.
there, and is it more of? I think it goes beyond that, right? And
It
so,
does.
like,
It does.
yeah.
Yeah, it starts with the original studies back in the 50s, when they were trying when one of the original researchers, who's a physiologist, was trying to determine what is the connection between atherosclerosis and what they were measuring in the blood. He came up with the problem being saturated fat and cholesterol. And he made that broad generalization. It's probably that he said saturated fat was the problem, and then it got just assumed that cholesterol was the issue. When we look at it, as the years have gone by and we've tried to reproduce those studies, those were not reproducible. And then when we looked at the old studies that and in detail and how they were performed, methodological problems in the way that study was performed too. Talking specifically about the 7 country study. So that was what was foundational for a lot of policy changes and recommendations originally. So the generalization started back then, and it was associated with saturated fats. As we've gone into the modern era, that has not been corrected in the in sort of the lexicon of practicing medicine. And then the dialogue continues to just be about cholesterol when the studies and follow-up clinical trials show that it's actually LDLs that are the problem. LDLs, when we look at experimental studies and population data, are what is associated with atherosclerosis more often than not. Low HDLs, high LDLs are the problem. And then when you associate that with, say, with diabetes or inflammation, then we have that compounding problem that leads to atherosclerosis. So it's not one thing; it's a complex, layered series of events and issues. And it's not cholesterol per se, because cholesterol is something that we need. It's important. It's used in high amounts in our developmental years. We use it less once we're developed, but it's still got a use in our immune system, in our health. It's it's used to heal, and we don't necessarily need high amounts of it, but we do need some of it. And so that's where the argument starts to happen. Where how much do you need, and who you see will have a different opinion.
Exactly. So, and I'm glad you said that because that's kind of the thing where you think this whole, and I had a great podcast with Dr. Paul Anderson. He's a
Mhm.
naturopath, man, brilliant doc. And we were just talking about how it's not so simple as HDL and LDL. Because
Yeah.
you can have someone, it's like, oh, HDL is good cholesterol. And it's like, wait, your HDL is 150. That's
Hmm.
not good. That's not
Yeah.
good, right? Or you can have a high LDL. And if I run an NMR or this whole, detailed look at the particle
Hmm.
sizes, what if your small LDL is 100? And it's like, well, that's not a bad thing. Or
No.
if you have a lower particle number, right?
Hmm.
And so one thing I've learned from, hearing you lecture and just some of the lectures we've done in the peptide space or longevity space is that there's these same things that cause all the different chronic diseases. When we think
Yeah.
inflammation, we think oxidative stress, we think mitochondrial dysfunction. These same things make heart disease a higher risk or can worsen
Hmm.
heart disease. And so that's really fascinating. So I wonder if are we looking at it backwards? Is like,
Yeah.
should we, I mean, obviously you don't want to just say, yeah, ignore the LDL, but I wonder, my kind of question is, should we start looking at these things a little bit more with more scrutiny when we start looking
Yeah.
at the cholesterol numbers?
Yeah, I agree. It's my approach these days is about urgency. It's important to know, when someone's coming to me and and they want to say they want to do something basic, like they're coming to me for longevity and they want to start with weight loss and they want to start with just being healthy. That's a great place to start. But the first thing I always want to do is assess their cardiovascular risk. So I'm going to do a clearly scan, or I'm going to do some sort of a CCTA, a CT of the coronary arteries, because I want to know, is this person at risk? If they are, how much plaque do they have? And how quickly do I need to address this? If they are not at risk, then I don't have to be as aggressive with the LDLs right off the bat. And I can work on the cardiometabolic changes. I can do things more from a foundational standpoint, sort of do like a grassroots, impact, start with their metabolism and change the way that their metabolism works and works with fat and inflammation, and because I know that there's no acute risk. Alternatively, if I see somebody that has a lot of plaque and it's inflamed and they're at a higher risk, then I have to attack that, because that's something that could potentially lead to a heart attack. And that's definitely something that we have to avoid. So sometimes, it needs a paired approach, something that deals with that acute issue, because there's only a few ways that we know of reducing that right now. We have a lot of tools, and it involves reducing inflammation, reducing LDLs, and trying to improve HDLs. But if we don't see that inflamed plaque, then I can do it slowly and not have to really be aggressive with cholesterol. So it goes back to that individualized approach, but it's also and is using urgency as sort of my guide.
Okay. Well, that's great to know. It's good to know. Now, let's kind of get into the nitty gritty of hypertension.
Hmm.
And so hypertension, if you Google it, you look at the articles, the silent killer,
Yeah.
right? It's almost like some murder mystery kind of thing, right? So it's hiding in the dark, wearing a mask and all that.
Yeah.
And I get that because a lot of people with high blood pressure don't have symptoms.
Hmm.
But what makes uncontrolled high blood pressure or extremely high blood pressure that's not managed or even addressed, what makes it so dangerous?
You can live with high blood pressure and not really even know it. That's part of the problem. I mean, it's similar to atherosclerosis. High blood pressure will slowly increase and accumulate, and it is an indicator of other issues, other inflammatory issues. Other dysfunctions in the person's metabolism, and that can go down to the cell for sure. But it's a slow, steady, progressive increase in the blood pressure to a point then that it can put a patient at risk for these really major life-threatening and life-limiting events. So, the person can start having a blood pressure that go, in the systolic range of 150s, and they won't feel anything. Oftentimes, we see people come into the hospital with their blood pressure in the 180s, the systolic number, and the only thing they might have is a headache, and they've been living with this
Mm.
headache for a long time. And then the longer they have it in that range, the less prone they are having the headache. So it's a testament to our body's adaptability, but it's also to our detriment oftentimes, because then it'll mask a lot of what else is going on. And then when the blood pressure gets that high, then that's when there's significant vascular issues that can cause a stroke, can cause a heart attack, can cause kidney failure. It can cause a multitude of vascular issues, and those are just the acute problems. The chronic problems that are associated with it are even worse. We're talking about diabetes, talking about chronic renal disease, and then you're talking, there could be limb loss, vascular issues in the periphery. You name it. I've even talked about dementia. It can cause a slow progressive decline in brain function and be associated with Alzheimer's and vascular dementia.
So I want to circle back to the kidney thing because
Yeah.
a lot of times there's such an association between blood pressure and kidneys. When we think about the renin-angiotensin system and all these
Yeah.
things here. So is this more of a circular thing where blood pressure can cause kidney damage and that kidney damage can further worsen blood pressure? Or is it, which one's the cart, which one's the horse? Or is it going to vary kind of person to person?
Yeah, it'll vary person to person. Oftentimes, it's usually hypertension that's one of them. They will influence each other, and it does become a cyclical thing at some point. Oftentimes, it's more, the hormonal imbalance, the renin-angiotensin imbalance, will can be one of the secondary or one of the initiating factors of hypertension, but hypertension could be from a lot of different things. So, it depends on what the source is. A lot of it can be, vascular stiffness due to nitric oxide reduction that's chronic over a long period of time. Arteries become stiff, they become non-pliable, also retain inflammation that causes scar tissue. So you can see how that vascular tissue can change if that becomes stiff and it doesn't buffer blood pressure. It doesn't have the flexibility that'll increase the blood flow to the kidneys. And then it also, in the kidneys themselves, have a dysregulation of how the blood flows through, because there is a buffering mechanism. And if that's not buffering the blood pressure, those filtering mechanisms in the kidneys can get blown out too. And so yeah, it's tough to tease apart. Usually when you have one, there is the other. But essential hypertension, basically hypertension where we don't know the exact cause, is probably going to be the first initiating event.
So this is where it gets kind of fun. We'll talk about diagnosing,
Yeah.
right? Because again, when you think about how do you know you have high blood pressure,
Mhm.
you go get your blood pressure taken at the doctor's office, and then it's like, oh man, this is high. You got high blood pressure. But standard of care, I believe you need to have 3 readings,
Yes.
3 separate readings
Mhm.
high. And then and this is one I remember at A4M, I heard Dr. Mark Houston speak about making sure you have the stationary, you have the prone, or ambulatory
Yeah.
blood pressure. But and then there's white coat syndrome, right? You're going to have people that's like, oh God, the doctor's here. I know I've
Mhm.
been eating burgers and fries for the last 3 months. I know it's going to be high. Oh God. And then it's like
Yeah.
through the roof, right?
Mhm.
So from your perspective, what's your kind of standard for, hey, you have hypertension, you have high blood pressure, let's go after this? Are you looking at that first reading or are you like, hey, let's come back and do multiples?
I'll do both, but that
Mm-hmm.
first reading is an indicator.
Mm-hmm.
If I know of the patient and I know that they have white coat hypertension, then I'll take that with a grain of salt. But white coat hypertension is its own thing, and it is now being realized that it is a precursor to potentially developing hypertension, or it could be an indicator of pre-hypertension. The reason is because we're all designed to have the variations of blood pressure. Our blood pressure is going to go up with stress states, goes up when we exercise. The range of normal for when we exercise can be up to 180 systolic. So that's a pretty high blood pressure. And when we're looking at your normal being 120 over 70. So we have the capacity to have it increase for short periods of time, and it's still within normal range and even be healthy. So if I see somebody that comes in with what we're calling hypertension, that could be initial malfunctions of the artery's ability to relax, to dilate. Could be a deficiency in that nitric oxide release, because the lining of the artery has this specific hormone, or it's actually a gas. It's nitric oxide, and it releases that and allows the arteries to relax, so that the pressure goes down and buffers the stress, and that elevated pressure keeps it from happening. So if I see somebody with a white coat hypertension, which is defined as elevated blood pressure, when they come to see the doc wearing the white coat, then it could be an indicator that there's something brewing. And if it's happening regularly, then it may be even more of an indicator. So that's one thing. And then when they come back, if they have multiple readings that are elevated, definitely that I'll be much more aggressive and apt to start some antihypertensive therapy.
So, what are your thoughts on the at-home test? So, you got the wrist cuff. They've got some that go around the arm. They vary in price from. I think I bought one for $20 one time. I was like, oh man, this is great. This has to be accurate. $20. This
right.
is it. This is it. I put one over on the doctor. So, what are your thoughts on those? With their accuracy, or is it more just the trend that you can track with those?
Well, the trend is important, but it is important to get an accurate reading. The wrist cuffs are convenient, and portable, but they're notorious for being a little too inaccurate. Because it's a smaller cuff and the blood vessels are smaller in the wrist, we're going to get misreadings, maybe higher than normal. Arm cuffs are going to be the best way to go. So that will access a larger artery, more accurate readings. So I think that the arm cuff is the best one to go with.
Okay. Good to know that. I don't still use that $20 cuff, man. I have a nice one here in the office. I got the real deal, the nurse fatty one. So we use that enough. Now, while I have you here, is the cuff size important? Because I know sometimes we, like a bigger guy. So if you're a larger guy and they break out the blue cuff, is that going to affect the reading if the cuff is too small or if it's too large?
Yeah, it is. If someone like you comes in the office and they get a small cuff, your blood pressure readings are going to be higher than expected. So because it gets tighter, the pressure, the way the pressure is measured in the cuff, it causes higher air pressure in the measurement, and it's going to read as higher. So looser cuffs will tend to be read as lower blood pressure. So it is important to get the proper fitting cuff too. Definitely, great point.
Okay, so we know checking the systolic or diastolic is kind of like the standard for diagnosing or assessing high blood pressure. But are there any other lab markers? And we talked about the Clearly analysis and the CCTA, but for labs themselves, are there any other markers that you would use beyond the standard blood pressure reading to assess or kind of work up high blood pressure?
Yeah, there's some basic labs that you'll always get from your physician, the comprehensive metabolic panel. And then sometimes, the comprehensive metabolic panel is important because it looks at kidney function. It looks at creatinine. It looks at creatinine and BUN, the blood urea nitrogen. Those two, when you look at together, give you an assessment of kidney function, and that is definitely correlated with blood pressure. So that's an important one. When we're looking at other tests that can contribute to hypertension that may be more inflammatory, sometimes uric acid can be an inflammation test that might allude to some of the issues with blood pressure. There is a test that looks at nitric oxide. It has variable accuracy, but that may be useful. It's called ADMA, arginine. It's something arginine dimethyl. I forgot the actual name from it. You can look it up in a minute. But the acronym is ADMA. It is it counteracts. It's a natural compound that counteracts nitric oxide. So when this is elevated, you're not making enough nitric oxide, and that can impact flexibility of the arteries, as I've said. Uh, Back to what you were talking about, renin and angiotensin can be measured. Aldosterone can be measured. These are indirect or sort of secondary indicators of blood pressure. And sometimes in hard to manage blood pressure, we might want to test those, because those will be if those are elevated or off, they may be the cause of that blood pressure. Important to remember thyroid function too, because thyroid function, whether it's underactive thyroid, or hyper overactive thyroid, those both can cause elevated blood pressure through different mechanisms.
Okay. Gotcha. One of the labs that, and I say this in transparency because one of the harder labs I have to explain to people is homocysteine.
Yeah.
It's not an easy one to explain. It's like, hey, you have this homocysteine and there's this MTHFR pathway, and it can go. And by the time the eyes go glassy, I'm like, all right, you know what? I got to go about this a different way.
Yeah.
And so, and you can, and I would love for you to correct me if I'm incorrect on this. So one of the ways I've been explaining homocysteine is I use the highway analogy. And so you want nice solid flow on the paths or the roads of the highway. So this one pathway can make methionine that holds the neurotransmitters, and you have another flow of traffic that can end up making glutathione via cysteine. And so if there's a traffic jam and traffic builds up and it's not going anywhere, and now these cars are not moving, cars idling on the road, the oil's coming out of the engine, you're getting all these fumes everywhere, and now the vessels get damaged. And that's the whole homocysteine thing, because it's not turning into the things, it's not metabolizing into the things it needs to metabolize. And then homocysteine damages the blood vessels, and that can lead to endothelial dysfunction, and that can lead to hypertension. Now, that's how I've been explaining it. Is that insane, or should I just say I need to call everyone and be like, look, this homocysteine thing is now what I was thinking, because what I've seen in some patients is like, hey, your homocysteine's high, and we're going to address that with some B vitamins and some trimethylglycine and maybe some SAMe, the different supplements that can help it. And some of these patients, their blood pressure is actually improved. And so it's like, wait a minute, is this it's indirect, but is homocysteine something we should be looking at when it comes to our hypertension patients? Or is that just was that a random kind of occurrence that I saw that?
No, homocysteine is definitely something that plays a big role in vascular health. So as you improve the vascular health overall, you are definitely going to be improving the blood pressure control, because we're going to be controlling the vascular inflammation. Inflammation is directly related to blood pressure control. So your analogy is good. Homocysteine is not just, it's an anti-inflammatory compound, but it's something, and it's a problem when it becomes elevated, because it overloads the system, and then it causes it causes deficiencies in other detoxification and metabolic pathways. So when you take the load off of that, it allows your system to regain its ability to manage inflammation, and then the ability to control inflammation in the blood vessels. So the analogy is great. I may end up using it.
Okay, thanks. Anytime. Analogies are my thing. Anyone that knows me, it's how I helps me understand. I think people relate to that, because you kind of get into it can get complicated. As you know, and I think it's important for people to understand. And so, speaking of understanding, when most people think inflammation, they're thinking pain, heat, swelling. I sprained my ankle. I ate a chocolate sundae and some cheese with it, and all the inflammatory foods, right? And so you're feeling that. So, but we don't think heart disease, and sometimes we don't think high blood pressure. So how does inflammation contribute to high blood pressure and heart disease?
There's a lot of different ways, and it's a multi-layered situation. So inflammation, when we're talking directly about atherosclerosis, when those LDL particles are going through our blood, if they're small, dense LDL particles, or if they have lipoprotein little a on them, or these proteins that sit on the outside of that particle, it'll help that particle attach to the lining of the wall of the artery. So when it does that, the LDL inside there will migrate underneath that cell and burrow into the artery, and it'll get there maybe because there's a reason why the body's delivering cholesterol there. Maybe there's too much cholesterol. It's just overloaded our body's ability to manage it. Either way, it gets burrowed underneath the endothelium and underneath that's one cell layer thick lining, and it'll sit there. And in a perfect world, the HDL will come and it'll be able to remove it, take it out, and it doesn't cause a problem. If it stays there long enough, it'll become an irritant, and that will trigger our immune system. And then that's when our immune system, when it gets triggered, will create inflammation. So that inflammation will change that LDL particle into something more toxic because it's going to try and absorb it and get rid of it, but it's really hard to do. Oil and water, because most of our body is water, just doesn't mix. And so the macrophages will go there, it'll try and engulf it, it'll bring other things there that are inflammatory, and then that's a weakness in the artery. Maybe more LDL will get put there. So it starts a cycle that's hard to break. But that inflammatory cycle ends up creating more problems when there's fuel that keeps getting put into it. And that's where this idea of inflammation happens. Uh, there's a bunch of blood tests that we use to measure that. hs-CRP, high sensitivity C-reactive protein, LPPLA2, which is the enzyme that converts the LDLs to more toxic, inflamed LDL. Then you can actually measure content of oxidized LDL in the blood, which if that's in the blood, it may not be what's in the artery, but it's a good secondary indicator. That other test that I was trying to remember about nitric oxide, ADMA, it's asymmetric dimethyl arginine. That's a sometimes a handy test to look at the nitric oxide, but it's subject to a lot of error. And then there's enzymes that our white blood cells, when they get really activated, will secrete that are going to try and fight this inflammation or infection that might be happening. And that can actually wear away at the lining and then make somebody prone to a heart attack. So there's a lot of layers to the inflammation. That's not even talking about when when we charge up our adrenaline system, the sympathetic nervous system. When that gets charged up, that also causes inflammation. So that's sort of, we talked about hypertension. That's how hypertension can be associated with inflammation. If we get a high sympathetic tone, a high amount of adrenaline, people that feel like they have a lot of, when their cortisol is also pumping all the time. All of these things, they generate inflammation. And that is, the slow chronic path that leads to creating more of the LDLs becoming toxic, more plaque, and then leads to heart disease.
That's awesome. Thanks for sharing that, because again, we're always, I think it's Dr. Sahar Sweeton. She's always like, we're all inflammatologists.
Yeah,
in many ways.
right.
That's our thing. We want to reduce that. So now, speaking of hormones, I know you talked thyroid a little bit earlier and just kind of sprinkle cortisol in there. So when we think about risk factors for heart disease and high blood pressure, usually we're thinking genetics, family history, we're thinking diet, but hormone imbalance clearly plays an important part in that. Are there any other hormone imbalances or dysfunctions that we should be keeping an eye on when it comes to heart disease, or even high blood pressure specifically, but even heart disease in general?
Yeah, I'm a big supporter of testosterone therapy, and testosterone. The reason why I think of testosterone is important for men and women is because it really supports our vascular health in multiple different ways. That lining of the artery, the endothelium, has receptors for testosterone. It helps to maintain health with testosterone. Helps to maintain nitric oxide levels with testosterone. Testosterone will help that layer stay healthy on a metabolic cellular level. It'll help that layer reproduce when it gets injured. It helps. So we have stem cells everywhere in different parts of our body that help to replace old cells and regain function. It does it for our endothelium too. Those are called endothelial progenitor cells, and testosterone helps to keep those robust and to function when needed. So there's a lot of benefits, a lot of importance to having testosterone at optimal levels. And then that's just directly related to the vascular system. When we look indirectly, because testosterone is also very profound in muscle health, that helps to pull glucose out of the system, maintain a nice homeostasis of glucose. It maintains a low inflammatory environment. And then it'll also help with, muscle health has its own hormones it actually releases, myokines, that can help maintain good function too. So, there's a lot of direct and indirect benefits of just testosterone. Then when we look at estradiol as a testosterone metabolite or as a primary product of it on its own for women is important for HDL metabolism. It helps to maintain HDL health and improve in high HDL levels. That's important because HDLs will help to pull the LDL that's deposited out of the arteries, and that's a process called reverse cholesterol transport. So it takes it out of the arteries, delivers it to our liver, and then we excrete it out through bile. So when a woman goes through menopause and their estradiol levels go low, within 10 years of menopause, they'll start to have age-matched risk for heart disease compared to age-matched men. So the protective effect that women tend to have is believed to be from estradiol. So two really important ones to name them, just right off the bat.
And I don't know if you saw this. Was it last week? The black box warning came off of
Yeah,
testosterone. It's about time.
it
Oh my
is.
God, dude, it's ridiculous, man. And I've had patients. This goes back to the war against, functional medicine,
Yeah.
if you will. And I've had patients who have come history of heart disease, and I'm like,
Hmm.
oh man, and you see the labs, and God, you have a testosterone of 120.
Yeah.
This is a problem. And we talk about the ways we're going to manage any side effects of it and make sure their estrogen doesn't go too high, not going to excessively dose them.
Hmm.
They're like, oh, this is great. Can't wait. They go see their cardiologist and they come back with their head down. Like, you said, don't
Yeah.
do that. You said, don't do it. It's going to kill me. And I'm like, and it's like, you guys don't answer the phone. I can't call you.
That's
You're not
right.
going to answer the cardiologist not going to answer the phone. It's like, tell him it's Dr. Jones. And they're like, yeah, I know where he's calling. And you don't hear him. But no, it's good that that's happened. And I think that's amazing because, the studies show the benefits of testosterone and hormone
Yeah.
optimization for this. And I think it was about time. And I'm so happy that happened.
Yeah, it's a
Yeah.
step in the right direction. It's the discussion about testosterone being safe is a moot point. I mean, we have almost 100 years of data to look at the safety of testosterone, and only because of a few handful of poorly designed studies in in what was it, the 2000s. I think that's what it was, like 2014, 2010, around that time frame. That's when it became a real big problem, and that's when those studies were getting a lot of press, but they didn't have a lot of validity. And then even when the authors retracted the studies, they still didn't reverse a lot of the myth behind it and then the concern. So this is a step in, definitely a major step in the right direction. And I would argue that the discussion about safety of those hormones should probably start to get suppressed here. We should start to put that behind us and actually start having a discussion about these being therapeutic. They should be part of therapy, because when I see patients that come to me after having a stent, after having a heart attack, and their testosterone levels are, like you said, in the hundreds, in the 200s. The studies show that patients with total testosterone levels in those ranges have a higher risk of dying of a heart attack. And patients that are treated with testosterone have up to a 50% lower mortality rate. So, like, where is that data getting lost? Like, why is that not getting to these cardiologists and other practitioners? I don't know, but I'm hoping that this is a first step to getting that information out there.
So thinking of things that were old and we know are not exactly true,
Yeah.
exercise when it comes to heart disease and high
Mhm.
blood pressure. And so, when it comes to that, you look at some of the older studies and newer studies, and even we learned, and see, I came in the game a little late with medicine, but again, it's just like, okay, the concept of cardio
Yeah.
or cardio as an exercise, like sitting on the
Mhm.
bike doing the hamster wheel thing, is like, of course, the name cardio
Yeah.
clearly makes you think this is good for your heart health, right? It's like
That's
it's
right.
quite the marketing ploy right there by the makers of treadmills, right?
Totally.
And nothing against treadmills, right? But some of the newer studies are showing that resistance exercise and high intensity interval training and even
Mhm.
static isometric things are improving or are better for high blood pressure. And you coming from an athletic background, what are your thoughts on that? And how do you incorporate exercise into your patient's care when it comes to heart disease and blood pressure?
Yeah, exercise is foundational in every patient's care. If they're coming to me, I make sure that they have some sort of fitness program. If they don't, I get them started on something, because whatever it is that I do, whatever medications I start, it's only going to get augmented. They're only going to have a better effect if they have a exercise program. And you know, there's a the one of the foundational lecture circuits that we go to always talks about exercise being one of the most powerful tools that we have to make substantial changes to our health and our future health. You know, it changes the way our cells function in a way that can optimize their adaptability and their resilience in the future. So yeah, it's a discussion for everybody. And I never use the term cardio, because it's not cardio; it's aerobic activity, because we want to distinguish the two. One is aerobic, one is, you could call it anaerobic, but I'll use, weight training. So, because you can get anaerobic with, that type of activity, with that type of exercise on a treadmill. So anyway, what I do is I make sure they have about 2 days a week of low intensity aerobic activity. I try and get them to do about 3 days a week, if possible, 2 to 3 days a week of weight training. And if that's all they do, great. And certainly that's on a patient that's already got the motivation. If I'm starting from scratch, I'm just going to have them walk. I'm going to have them walk
Mhm.
3 days a week. Let's do that. And ideally, the best time I would recommend to go for a walk is actually after your meal, after dinner, because that can help to control the glucose, the glucose response, the serum glucose response. It will help to the large muscle groups will absorb the glucose better, and you won't get as high of a spike. So you can go and do some low grade activity after eating. It's healthy, and it's not going to cause any problems. That's great. Do that 3 days a week, and maybe go for a half hour. If they can, go for an hour. Start with that. If they're doing that, then I'll start incorporating a little bit more low intensity, which, a lot of people just describe it as zone 2, which is around 120 beats per minute or less, and it's a low intensity but steady state activity, and that can help build good foundational aerobic capacity, help create good foundational mitochondrial health, and then pair that on other days with resistance exercise. Now, resistance exercise will improve how your muscles recruit glucose in higher intensity activities. It'll improve the mitochondrial function of the muscles, so that they can also have longer term better uh, utilization of not just glucose but fats. And then it also helps with nitric oxide balance. So that resistance exercise helps, because your body has to learn to deliver blood to muscles, and they have to enlarge. That pump that people get when they are pumping, they're lifting
Mhm.
weights, that's nitric oxide. That's opening up the blood vessels so you can deliver more blood and more blood flow to those muscles so they can function. So that happens more with weightlifting. The more you do that, the more that endothelium, that lining, releases nitric oxide so that you can deliver more blood. The more it does it, the more better it gets at doing it, and the more healthy your muscles and your blood vessels are. So, and then finally, after they've gotten those two things done, I'll add in high intensity intervals. And that could be as little as 1 to 2 days a week. And high intensity intervals, true high intensity intervals, or, if we're talking about a sprint, it's an all out sprint for, say, 30 seconds to a minute. Take a 30-second to 1 minute jog, and then do it again. And you alternate that for 6 times. And that's enough right there. That can actually stimulate hormonal changes. That stimulates of a maybe well, it stimulates growth hormone, testosterone
Mhm.
improvements, and that can also have downstream effects, meaning long-term effects on improving metabolism and energy utilization.
Right. So exercise is key. And
Yeah.
I think that's good, because I think it's very easy to, any textbook is going to say, hey, you have high blood pressure, you have heart disease, or even high cholesterol, you need to exercise. Great. But how?
Yeah.
Especially for someone who doesn't have a strong foundation in exercise and fitness. I
Hmm.
think knowing where to start, and I think that's great that we start slow and then ramp up. You gotta start somewhere. A
Yeah.
lot of times, if someone's already coming in with some of those other kind of ancillary things, like, hey, my testosterone is low, they probably don't have the motivation to work out.
Yeah.
And so it's building them up to that point. Now, aside exercise, are there any other lifestyle recommendations that you're like, hey, here's foundational lifestyle things you need to do if we're trying to help you lower your blood pressure?
Yeah, definitely. I mean, the next thing, the first thing actually that I always ask my patients is about their sleep.
Mm.
Sleep is vital for all of our functions, and in so many ways, so important for hypertension and hormonal health. When we look at poor sleep, it's going to increase your sympathetic tone, so increase that adrenaline tone, and then something like sleep. That's just poor sleep on its own. It'll increase your blood sugar, and it'll decrease your ability to manage sugar as well on the following day. And then it actually impacts hormonal changes too. So it'll reduce your testosterone, serum testosterone levels, maybe reducing your ability to have the motivation to get up. You're going to be tired. Your exercises on their own are going to be impaired. What's that going to do? And it's going to cause you to take caffeine stimulants that will probably end up impacting your next at night's sleep. So that's one thing. That's just with poor sleep on its own in a normal person. If we take this a step further and we look at, say, something like sleep apnea, that's a major issue then, because then you're actually getting I mean, literally, you're getting suffocated slowly. Sleep apnea means you are not breathing, and depending on how severe it is, you could go minutes, you could go minutes without having good oxygenation. So you're basically not getting any oxygen to your brain and to the rest of your body. That is going to be an incredible stressor. It's going to release cortisol. It's going to release all of those stress hormones so that not only do you not sleep well, but then afterwards, your body is trying to recover from that under oxygenated state. So that is a high risk for hypertension and for worsening hypertension, high risk for atrial fibrillation, so the arrhythmia problem of the heart, dementia, atherosclerosis, diabetes. So as the sleep gets worse, the problems start to mount, and what do you do? I mean, end up starting taking medications to treat that, which may end up contributing to the problem.
Oh man, that can get rough.
Yeah,
That can get rough. Now, so it's funny. I wish we presented at Calm, and I did a lecture on sleep, and
yeah,
I only had 30
great
minutes, man.
lecture.
I wanted to, thank you. I wanted to get into sleep, but again, I hope Leonard and Franco listen. I only had 30 minutes.
Yeah,
Hence. And so I really couldn't get into it, but I'm glad you brought that up as well. Now, outside of sleep, one thing for me is, and of course, I know the connection, but when you see it in your own life, was alcohol.
oh
And
yeah.
not that I was a big drinker, but I partook a lot more than I do now. And I
Hmm.
was like, man, my blood pressure is high. Like I
Yeah.
started taking supplements. Like, look, I got to lower this down. This is weird. And of course, I thought the stress of opening a practice, but you know, when I actually cut the booze way back, my blood
Hmm.
pressure literally went back to it dropped almost like 20
Oh yeah.
millimeters, like,
Hmm.
top and bottom. I'm like, oh, this is incredible. So is it the inflammation that alcohol causes, or is it just the strain it puts on the kidneys? But what would be kind of like the link between alcohol and high blood pressure?
It's multifactorial. It's
Okay.
because alcohol, it's going to affect your sleep. That's the first thing.
Hmm.
It's the sleep quality that you get when you're drinking close to bedtime is much worse. And so that reduction in sleep quality is definitely going to be a contributor. Alcohol itself is a poison. It's there's no way around it really. I mean, I love a good cocktail, but at the same time, I know that, and if I'm going to drink, it's a conscious decision, but I also know that it's a poison. So how much of it can we take it is individualized, but that poison causes inflammation. So it's going to cause an issue with the vascular system. And then it also, it's going to stress the liver, kidneys. I mean, when we look at it, basically all of our systems don't function well with alcohol, especially when you're taking it higher amounts, higher quantities.
Oh man, it's good to
Yeah.
know. Moderation,
That's
moderation is
right,
a key, and,
moderation, mhm.
and so many things. So this is one of my questions I've been waiting to ask, man, because I'm a naturopath, dude. I love supplements.
Yeah.
It's like, and it's like I have 1,000 supplements at our disposal here, but are there any go-to supplements that you recommend in your patients? And we know it's case by case and individual, but do you have any favorite supplements when it comes to helping with blood pressure?
Yeah. When I'm looking at blood pressure, there are sometimes I'll add taurine to patients that are higher stress, that I see that tend to have a higher sympathetic tone. That can sometimes relax it. The challenge though is the how many grams you got to use, and that can go
Mhm.
up pretty high. But taurine is, and it can go as high as 6 grams, which is a lot,
Mhm.
and it's done in divided doses, so it can have tolerability issues. When I'm looking at hypertension that's uncontrolled, and I'm thinking of supplements, that actually takes me to gut health, because a lot of times there is a good there's a good correlation of gut health to hypertension, and that's often where supplements and herbs can have really good impact. When there's an imbalance in microbes, or when our gut is showing inflammation, then that can trigger hypertension and make the blood pressure harder to manage. It won't be managed with just standard antihypertensives. So I'll look at the microbiome. I'll try and rebalance that if I need to, see if there's any inflammation there. So gut supplements are going to be really helpful. And then some off-label things. There's some data that says that even like whey protein, small amounts, can act like an ACE inhibitor. Um, what else? Those are the big ones that come to mind. What about which ones do you use? Do you have any go-tos?
Oh, of
Yeah,
course, man. The N is never saw a supplement I didn't like in
that's
the
right.
NMD, right? So, there are a few that we don't like with blood pressure. So magnesium's a huge one.
Definitely, yeah, I
Uh, so,
agree.
so but magnesium's huge.
Mhm,
So many, man. You mentioned taurine is great.
mhm,
On the herbal side of the house is Rauwolfia, which can be a little strong. It's pretty. When you look at some of the studies, it's can have some of the, I wouldn't say lisinopril like, but taking high enough dose of Rauwolfia can really lower blood pressure.
mhm.
There's so many, man. I'm sure hope my botnet professor is not listening to this. Like, dude,
Yeah,
you
yeah.
should be spitting them out. So there's coleus, there's crataegus. There's a lot of really good ones here. Garlic actually has some good
Mhm.
studies for helping with blood pressure as well. And
I'm
so,
glad you mentioned magnesium. That's
mhm,
you can take grams of that depending on
mhm,
on GI tolerance, but there magnesium is great for blood pressure, as
mhm.
that magnesium helps to relax the calcium
Vessels, yeah.
channels, allows those
Mhm,
arteries to get more dilated. There's a whole market for nitric oxide supplements, and I don't tend to use them. I think that they work. They're helpful, but it's not addressing the underlying problem, which is, are the cells healthy enough, that lining of the cells, to make its own nitric oxide?
right,
So we can use them as an adjunct, as an add-on therapy, but in addition to other ways to help control the blood pressure. I'm sorry, help to control or rehabilitate that lining of the artery. Um, yeah, and then the other one that came to mind as we were talking is it's not a natural supplement, but it's a repurposed medication. The Cialis,
mm,
low dose
yeah,
Cialis
yeah.
is
Mhm.
helps that lining of the artery, and it dilates blood vessels too. It opens them up. That's how it works as an erectile dysfunction medication.
Yep. Another two that I really like, and I'll call them more food sources and supplement sources. And just for the sake of time, man, we can have a whole other podcast on the
Yeah.
DASH diet and the Mediterranean diet and,
Hmm.
avoiding high sodium diets. But I really like celery stalks.
Mm.
So celery, and usually a lot of our hypertension pays are like a little bit high, borderline high. I'll say, hey, if you dig celery, two to four stalks a day, raw celery, don't cook
Hmm.
it. Really good. Throw a little peanut butter in there, get some healthy fats, and you're all good.
Yeah.
The other is hibiscus tea.
Mm.
Hibiscus is very good for that. And so especially our patients that we have some guys that drive a lot. They're driving around town for the job. It's like, hey, just make a pitcher, put it in like a thermos
Hmm.
or a drawing a blank. Those fancy ones, man. The metal ones. Why am I drawing a blank here, man? It's super expensive. I have the stainless steel mugs. Why am
Yeti.
I? Yetis, yeah. You got a Yeti. 3 to 5 cups a day, and
Hmm.
I've seen it lower. Systolic, diastolic, systolic, with systolic, diastolic. man, almost, 7, 8, 10 milligrams.
Wow,
So
nice.
pretty solid. It's just consistency, right? Because it's
Yeah.
like, hey, we want to get to the root cause, but in the meanwhile, it's like, hey, this can help. But I think a lot of times people do it for a month or two, and like they kind of cut back. There's only so much celery a man or a woman can take, right?
That's right.
So, anyways, but
Mhm.
it's a good start.
It is.
It's a good start. Now, and this transitions me to the supplements we want people to actually not
Yeah.
consider or kind of avoid. And one, I don't know if you said in your clinic that it's so easy for someone to get online and Google and say, wow, this really should help me lower blood pressure.
Yeah.
And they say, hey, I'm taking potassium.
Mhm.
And I'm like, you got to be careful with that.
That's right.
Just because you can get hyperkalemia
Mhm.
very easy.
That's
All
right.
right.
Yeah.
So I'm concerned with that. But outside of potassium, are there any other supplements that people should maybe think cautiously about when it comes to blood pressure?
Yeah, the licorice is one of those because licorice can stimulate elevated blood pressure via, I think, is it through cortisol? But high licorice consumption, it's not common, but that's something that we got to be cautious of in a hypertensive. You mentioned potassium in moderation. Um, what are the other ones? Yeah, any stimulants really.
Yeah. Caffeine, the
Any
pre workouts. Yep.
Yeah, I mean, especially in athletic in my athletic patients, if they're I think the age of fat burning pills is probably behind us because there's better molecules that help people lose weight safely. So, but there are still some old school folks out there that will use like those fat burners that they can get online, and those have high amounts of stimulants in them that can impact blood pressure. Anything that's caffeinated, power drinks, things like that. Um, yeah, I think those are the main ones that come to mind.
Okay. Yep. Keeping an eye on that and
Yeah.
just moderation, man. But definitely the
Mhm.
potassium, the licorice thing. And that one, because you mentioned gut health, I think that's one we have to make sure people are educated on because in a lot of the healthy gut, leaky gut supplements, they'll use DGL
That's right.
or the deglycerized licorice. And it's so easy to say, oh, licorice, let me take that,
Hmm.
which can have it still can help kind of heal the gut lining, but it also can raise blood pressure. So it's important people are doing that to make sure they're
Yeah.
getting the DGL versus
Hmm.
the traditional licorice. So next, and you mentioned it at Calm a little bit, and I definitely wanted to dive into it a little bit. So there's a lot of research, actually pretty compelling research on GLP-1 receptor agonists lowering
Yeah.
blood pressure. And so when people think GLP-1s, the first thing that comes to mind is blood sugar. Yes,
Hmm.
okay. Weight loss, yep, got it there. Appetite, cravings, all that good stuff. So how can these peptides, these medications that are used for those things actually help with blood pressure and
Yeah.
heart health?
Yeah, it's fascinating. It goes back to the direct and indirect effects. If we talk about direct effects, the endothelium, and I keep coming back to this, but that's a really highly active cell layer, and it's very important to our health. That layer has receptors for the GLP-1 hormone. So it will respond to that and directly improve the health and the efficiency on a cellular level of those molecules of those cells. So there's direct effects there. It reduces the ability of immune cells to grab onto that lining too. So we don't have as much adhesion of uh, of white blood cells or even potentially cholesterol molecules onto the lining of the artery. So it reduces maybe the potential for atherosclerosis develop as well as improves the health of that lining. And then it's an anti-inflammatory. So by doing that, it also improves the ability of that lining to be resistant to inflammation. There is by improving that the health of that endothelial lining. Again, it goes to improving nitric oxide. So it's a multi-layered direct effect, and then we have the indirect effects where weight loss, improved flexibility of the artery, reduced atherosclerosis. All these things have an indirect effect, improved blood glucose management, indirect effect in improving blood pressure. Now that I mean, and to put it in perspective, there is a blood pressure reducing effect. It's modest. We're not talking about double digits, but it's enough to be significant. And then if we combine that with weight loss, that's when we start to see significant drops. So by itself, independent of weight loss, a little bit, but when you have a substantial lifestyle changes, activity, and then metabolic changes, yeah, wow, you're looking at something that could lower it double digits or more.
And you hit a super important point there about the lifestyle changes and being consistent with that. Because
Mhm.
when you look at some of the studies, when people stop the GLP-1s, weight comes back,
Yeah.
and that's unfortunate. And I have to talk to patients about that. Like, hey, I really don't want you on this forever, but just know if you don't make these lifestyle changes, I think with one of the GLP-1s, I think they had like 17% weight loss. And when the person stopped it, they gained 12% of it back. Now it's still a net 5%,
Yeah.
but we have to be realistic with the expectations. So we always think about the lifestyle changes you can make while you're using it. So whether it comes to exercise and then
Mhm.
whether it be diet or supplementation, just get yourself at that balance though. So have you seen patients who've used the GLP-1s and they saw the blood pressure improvement and then they've stopped or cycled off of it? Have you seen the blood pressure kind of come back when they stop the GLP-1s?
A little bit.
Mm,
What happens is when patients cycle off of it and they start to see weight come back, once it gets to about a 10-15 pound weight gain, then they're a- and if they're still at a total of being lighter or negative compared to where they were before, most patients will resume the GLP-1 because they see that things are going in the wrong direction. They haven't been able to get ahead of it with lifestyle and diet. So then they'll get back on it. And that usually is we'll see a little bit of blood pressure increase, but then it'll come back down. So I think that some of those blood pressure effects are still maintained. I think there's something to the long term effects of these GLP-1 medications that improves the health of the lining of the artery, the endothelium, and improves their resiliency.
okay. Awesome. Awesome. So are there any peps? Because again, we're even at the conference this past or last weekend, we did
Yeah,
see a few presentations that talked about some peptides. Like, oh, I've never heard of this. I want to learn more about that.
yeah.
Are there any peptides or any other regenerative compounds or longevity compounds that you can see showing promise for improving or optimizing cardiovascular health?
Yeah. Well, the ones that I use a lot of apigenin. I think that's we talked about
Mhm.
other. It's not a anti-hypertensive, but it's a compound that is useful in atherosclerosis, useful in sleep, in reducing inflammation in general, useful in brain health too. So it's got a lot of powerful benefits to it. I consider that a longevity compound. I like I like telmisartan actually. If we're talking about hypertension and longevity, that's intersection of both of those. Telmisartan is an antihypertensive medication that's being shown to have longevity compound benefits. It's been shown to have almost what we call performance enhancing benefits, and at low doses that are not going to lower blood pressure. So even in a healthy normotensive patient, that's something that can be considered. Um, Talked about Cialis or Tadalafil. I like that as a longevity compound. But when we're looking at the other, say, peptides, one of my favorite ones to use, uh, testosterone. It's
Mhm.
secretagogue, something that improves growth hormone release by our brain. So it's our brain and our bodies are able to regulate it, so we don't get like that hyper growth hormone response. We don't get the cortisol or the side effects that are associated with, say, something like synthetic growth hormone. So it's more natural, it's safer, and that can improve the cardiac output, and I think that's really useful in improving vascular health. There are studies that show that we can reduce the thickness of the lining of the carotid artery, the intimal media. So when it gets thicker, it's a sign that it's unhealthier. There are studies that show it can actually make it get thinner and healthier. So
Wow.
counterintuitive, we think that if it's thinner, it's not as healthy. In the arterial lining, that's actually the case. Thinner, more dense, more resistant to inflammation.
Pretty cool.
Yeah.
So things to be looking out on the horizon, man. There's always some cool things coming out, and we'll always be on the lookout for those.
Yeah.
So before I get you out of here, man, a couple questions.
Mhm.
Um, so what are you most excited about when it comes to the future of cardiovascular health and treating cardiovascular disease?
Yeah. I talked about it before. I feel like the biggest change and the tool that we really have to leverage is going to be that Clearly test. I think that
Mm,
that's one of the most exciting things that I've seen in the past few years, and it has the potential to have profound changes in saving lives in the immediate future, because we can identify those people um, that are going to be at high risk and put them on treatment that'll save their lives. So that's
awesome.
major, and that's life saving that we have now. Going in, looking into the future, further imaging of the coronary arteries. There's going to be other tests that are going to look at inflammation that are actually going to
Hmm.
probably predict or predate the formation of plaque. So we may even have tests that can do that and see it in the preliminary standpoint. So that's something that's going to be exciting for in the next 5 years or so. And then I'm curious to see what other AI platforms are going to be available that can start to crunch some of this really large amounts of data to help determine what interventions are going to be useful for, say, HDLs.
Hmm.
There's a whole movement to get a HDL improving medication in the past. What was about 5-10 years ago? The CTEP inhibitors didn't come to market because they had actually showed worse outcomes. But there's still a lot of research because in that area, because it's still an area of lack of understanding. We don't
Hmm.
know how to optimize reverse cholesterol transport. Tesamorelin is something that can do that. Those medications can help. So that hasn't been tested, but we see that in the pathways in the experimental studies, which is another reason why I like it.
Right.
But improving that reverse cholesterol transport, in my mind, is going to be the bridge between being able to really find out what goes on in the whole spectrum of atherosclerosis and then how to treat it. So then we can really individualize patient care.
Awesome. Awesome. So one more, man.
Yeah.
One more. So if you could go back in time, hop in a time machine, and meet
Yeah.
yourself coming fresh out of your cardiology residency or fellowship, what's the one thing you would tell yourself? Hey, Abid, this is me.
Yeah.
It's future me. Listen to
Uh-huh.
this. You be like, invest in Apple.
Yeah.
Besides that,
That's right. I
yeah,
would, when I finished training, I was burnt out from studying, and I was tired of reading journals, and I took I probably didn't pick up a journal for like 5 years, something like that, and I was done with it, and I just wanted to practice. I would tell myself, um, follow your curiosity, don't stop reading, and look for information in odds places, because
okay,
that journey is what led me to functional medicine. It led me to hormones, and it led me to peptides. And that's really made me feel like I have a robust understanding of what's out there, and made me feel at least prepared to make an individual program for people that come to me. I
right.
didn't have that feeling after I finished my fellowship, and that's a sad statement, because that's like 15 years of schooling, and
Hmm.
still didn't have that capacity. So I would tell myself it's a lifelong process, and continue to look for things that pique my curiosity, and don't be afraid to go to odd places.
Okay, awesome. Love it, man. So, hey, I want to thank you for making time for this today. I really appreciate it.
Yeah, it's great to be
Before,
here. Thank you.
oh no, thanks, man. It's about time. I know we were kind of trying to get this together last
Yeah.
year. So, people that want to know about more about you and your
Mhm.
practice and the cool things you have going on, where can we find you?
Yeah, you can find me at Boulder Longevity Institute. So that's at boulderlongevity.com. And I work there with Dr. Betsy Earth. She's one
Awesome.
of the smartest people I know. And it's a real pleasure to be able to work with her on a day to day basis. Great team there. You can just go to the website and find me there.
All right, thanks. Appreciate it. And last but not least, you are an artist, an amazing
Mhm.
artist. Do you
So are
have
you.
Man, look, man, my pastel stick figure no longer counts here, man. I gotta, and every time I see you and your wife, man, like, I gotta start painting again, man, because it's
Mhm.
inspirational to me to have that release and also make time for that on top of your everything that you have going on. But do you have a website or any social media for your artwork?
I have, there is a website. It's called Movement and Color, all one
Okay.
word,
Okay.
movementandcolor.com. So it's
Okay.
got, I haven't updated it in a while, but it's got a lot of my older paintings.
Okay.
And then my Instagram page should have some of my older paintings in it too, but that's
Okay.
shifting more towards the more medically related stuff these days.
Okay. Well, I will definitely put the movement. Oh man, wow, go. I need
Movement and
man.
Color.
Movement and color. This is how I know it's time to eat. I need, it's time for lunch. It's like
Yeah,
it's enough fasting for me for a
that's
day.
right.
So movement and color. We will put that in the show notes.
Mhm.
Again, man, thank you so much for your time. Really appreciate you.
You
Have a
too, man.
great
Thank
rest of the
you.
week. Thanks.
You
So
too,
for you
brother.
guys listen, oh thanks, man. For you guys listening out there, this is Dr. Greg Jones signing off from the Optimization Academy. If you have any comments, questions, concerns, let me know. The show notes and the comment section will be available and open for you. This is Dr. Jones signing off.